Introduction. Welcome to the Peripheral Artery Disease Vodcast titled PAD and ABI Screening, Advancing Early Detection and Equitable Care. The Ankle-Brachial Index ABI test takes just a few minutes to perform but can reveal life-threatening vascular disease before symptoms even appear. This episode of the PAD Vodcast Series equips healthcare professionals with the knowledge and tools to improve early detection and management of peripheral artery disease, PAD. Focusing on ABI screening, this podcast explores disparities in care, key clinical signs, proper screening techniques, and evidence-based treatment strategies. Learn how to interpret ABI results, identify at-risk patients, and implement timely interventions through a multidisciplinary approach. This is part of the PAD National Action Plan. Peripheral artery disease is common. Over 230 million people worldwide are affected, including more than 10 to 12 million Americans. PAD is not just about leg pain. It carries a higher risk of heart attack, stroke, amputation, and death. Yet, diagnosis, treatment, and outcomes are far from equitable. A new interactive, non-traumatic lower extremity amputation heat map highlights the stark disparities across the United States, showing how geography, race, and socioeconomic status profoundly shape outcomes, with Black, Hispanic, and Native American patients at the highest risk. This vodcast will explore why disparities in PAD care matter, how tools like the heat map can drive advocacy and awareness, and why community-based ABI screening and early detection are critical steps to save limbs and lives. Let's explore the disparities. Topic 1. Disparities in PAD diagnosis and treatment. Sex and PAD. When we look at sex disparities in PAD, the prevalence of disease is similar in men and women, but the presentation and treatment differ significantly. Women often report more atypical leg symptoms, sometimes at rest, and these can be complicated by arthritis, neuropathy, or spinal stenosis, which makes diagnosis harder. Women with PAD have poorer walking performance and are more likely to develop new mobility loss over time. They are also less likely to be prescribed or adhere to statins, and when they undergo revascularization, they are typically older and more often treated for chronic limb-threatening ischemia rather than claudication. Biological factors like smaller artery size and reduced arterial compliance may contribute, but social factors, such as caregiving roles, access to care, and income also play a role. These differences highlight the need for more research and more equitable treatment strategies tailored to women with PAD. Race, ethnicity, and PAD. Race is a social construct that often reflects the impact of unequal resource distribution. In peripheral artery disease, PAD, this is most evident when comparing Black and white patients. Black patients have nearly twice the prevalence of PAD compared with white patients, with lifetime risks estimated at 30% in Black men and women versus 19% in white men and women. Black patients are also more likely to present with asymptomatic or atypical symptoms, lower Ankle-Brachial Index values, higher rates of diabetes, and poorer physical function. Treatment disparities further worsen outcomes. Black patients are less likely to receive guideline-based therapy, such as statins or antiplatelet therapies, and less likely to undergo revascularization before amputation. They face higher amputation rates, younger age at intervention, and worse surgical outcomes, with Black women at particularly high risk. Hispanic patients similarly experience higher amputation rates and complications after revascularization. Data for Asian and Native American patients are more limited, but they too experience variable outcomes. Importantly, these differences persist even after adjusting for traditional risk factors like smoking and diabetes. Socioeconomic and geographic disparities in PAD, prevalence, incidence, and outcomes. When it comes to peripheral artery disease, where you live and the resources around you make a major difference. Amputation rates are highest in the southeastern U.S., a region often called the amputation belt. These communities face higher poverty levels, limited access to healthy foods, fewer places to exercise, and lower availability of specialty vascular care. Patients in these areas are less likely to receive preventive treatments like statins, antiplatelet therapies, or supervised exercise therapy, and they're more likely to lose a limb at a younger age. Access to evidence-based treatments also varies. Supervised exercise therapy, SET, covered by Medicare since 2017, remains vastly underutilized. National surveys suggest fewer than 5% of eligible patients enroll, and participation is lowest in southern states compared with the Northeast and Midwest. Improving referral and program availability is a practical lever to narrow these outcome gaps. Local health system capacity matters too. In Texas, rural counties with more primary care clinicians had significantly lower amputation rates, while in North Carolina, medically underserved counties with no vascular surgeons and fewer clinicians overall had amputation rates over 1/3 higher than other regions. The story is clear. Socioeconomic disadvantage drives worse outcomes in PAD. Expanding access to primary care, investing in community-based screening, and ensuring equitable referral to vascular specialists are critical steps. By addressing the social factors that surround our patients, income, education, access to care, we can change the map of limb loss in America and reduce the burden of the amputation belt. Topic 2. Guidelines on screening and ABI testing. As providers, screening for PAD is essential. Who should be screened? According to the 2024 ACC/AHA SVS guideline, ABI screening is recommended for patients age 65 and older, patients age 50 and older with a history of smoking or diabetes, any patient with exertional leg symptoms or non-healing wounds. For people with diabetes, IWGDF, ESVS, SVS guidelines recommend annual foot exams with pulse palpation. If PAD is suspected, ABI, toe brachial index, TBI, and Doppler waveform analysis should be performed. How do we interpret ABI? Normal, 1 to 1.4. Borderline, 0.91 to 0.99. Mild PAD, 0.7 to 0.9. Moderate PAD, 0.4 to 0.69. Severe PAD, less than 0.4. Best practice pearls. If ABI is less than 0.5, the risk of non-healing wounds is high. Although intervention is not indicated unless the patient is symptomatic, close supervision and education of the patient is advised. In addition, if the toe pressure is less than 30 millimeters of mercury, this reflects poor healing capabilities of any foot wound. Remember, in patients with diabetes or renal disease, ABI may be falsely elevated due to calcified vessels. In these cases, TBI and Doppler studies are more reliable. The Wi-Fi classification system, wound, ischemia, and foot infection, helps estimate amputation risk and guide revascularization decisions in patients with PAD and foot wounds. Topic 3. Importance of early detection and treatment. Why does this matter? Because early detection saves limbs and lives. ABI testing can identify patients at risk before severe symptoms develop. Detecting PAD early allows us to initiate therapies that reduce cardiovascular risk and preserve limb function. Guideline-directed therapies for PAD include antiplatelet therapy with aspirin or clopidogrel, or dual pathway inhibition with low-dose rivaroxaban plus aspirin. In patients with symptomatic PAD, low-dose rivaroxaban, 2.5 milligrams twice daily, combined with low-dose aspirin is effective to reduce the risk of MACE and MALE. High-intensity statins for all patients. Smoking cessation with counseling and pharmacotherapy. Aggressive management of diabetes and hypertension. Supervised or structured exercise therapy. Revascularization for lifestyle-limiting claudication or chronic limb-threatening ischemia. Healthy nutrition, particularly adherence to a Mediterranean diet, plays a key role in both primary and secondary prevention of atherosclerotic cardiovascular disease, including PAD. Reducing major adverse cardiovascular events, MACE, lowering blood pressure, and improving outcomes in high-risk patients. To reduce disparities, we must focus on education and access. Patient education should be culturally tailored and accessible. Providers must recognize atypical presentations, particularly in women and minority populations. Systems should expand community-based ABI screening and ensure coverage for diagnostics. Policy advocacy is essential, with initiatives like the PAD National Action Plan aiming to close gaps in awareness, detection, and care. Topic 4. Conclusion and call to action. Disparities in PAD are real, measurable, and preventable. ABI is a simple, inexpensive tool that can change outcomes when applied equitably. By ensuring guideline-based screening, expanding access to therapy, and addressing inequities, we can save limbs and lives. Key message: every patient deserves early detection, effective treatment, and an equal chance to live free from the devastating consequences of PAD. Recognizing the signs: why foot checks matter. When it comes to peripheral artery disease, PAD, your feet can tell a powerful story. PAD often progresses silently, but the signs are visible if you know where to look. Let's start with a simple but vital habit: check your feet. This isn't just about hygiene, it's about detecting early warning signs of poor circulation. Here's what to look for. Color changes. Are your feet pale, bluish, or unusually red? These can signal compromised blood flow. Temperature differences. One foot colder than the other? That's a red flag. Pulses. Can you feel a pulse on the top of your foot or behind your ankle? Weak or absent pulses may indicate arterial blockage. Digital hair loss. Hair on your toes and feet may seem trivial, but its absence can point to reduced circulation. Skin texture. Shiny, thin skin or thickened toenails are common signs of PAD. Foot deformities. Conditions like hammer toes and bunions can worsen due to poor circulation and increase the risk of pressure ulcers. Shoe-related rubbing. Look for blisters, calluses, or red spots, especially if your shoes don't fit well. Note that patients may use other terms such as cuts, nicks, scrapes, and breaks in skin. These can become serious wounds in PAD patients. And don't forget the neurological symptoms. Tingling, numbness, or burning sensations in the feet and toes may indicate nerve involvement, often seen in people with diabetes and PAD. Claudication, that cramping pain in the legs during walking that eases with rest, is a hallmark symptom. Some patients also report rest pain, especially at night, relieved by dangling their feet off the bed. These signs aren't just cosmetic, they're clinical issues. Early detection through visual and sensory foot checks can lead to timely ABI testing and better outcomes. So, whether you're a healthcare provider or someone at risk, make foot checks part of your routine. It's a small step that could make a big difference. The Ankle-Brachial Index. The ABI is a non-invasive, objective measurement of the ratio of ankle systolic pressure to arm systolic pressure using a handheld Doppler to quantify the degree of arterial insufficiency. It is the most cost-effective tool confirming the diagnosis of PAD. It can easily be performed in the primary care setting for individuals who are at risk for PAD. Performing the ABI test is slightly more involved than taking a blood pressure, but it can be learned quickly and becomes easier with practice. Supplies needed: Doppler gel, Doppler probe, portable manual blood pressure machine, blood pressure cuff of an appropriate size for the patient tissues, bed or other horizontal surface such as a massage table. Procedure: 1. Have the patient lie in a supine position with shoes and stockings removed for at least 10 minutes prior to obtaining blood pressure measurements. Make sure patient is warm and comfortable. 2. Apply the blood pressure cuff snugly around each arm and around each ankle, with the lower edge of the cuff 1 inch above the antecubital fossa on the arm or above the lateral malleolus of the ankle. Usually, the cuff that is the appropriate size for the arm is also appropriate for the ankle. In the rare instance that the upper arm and ankle circumferences are markedly different, use the appropriate cuff size for each site. 3. To take the arm pressure, apply an approximate 1-inch ribbon of Doppler gel to the antecubital area. Be sure to use enough gel. 4. Turn the Doppler probe on and place it at the antecubital area over the brachial artery, covered with gel at approximately a 60-degree angle to the skin. Move the probe around until the clearest arterial pulse sounds are heard. Keep the probe in the position where the clearest pulse sounds are heard. Keep your eyes on the probe during inflation and deflation of the cuff and anchor your hand to ensure you do not slip off the brachial artery. 5. Inflate the blood pressure cuff to approximately 20 millimeters of mercury above the numerical reading where the arterial pulse sounds cease. 6. Deflate the cuff at a rate of 2 millimeters of mercury per second until the first arterial pulse sound is heard. When this number is determined, deflate the cuff completely and record this systolic reading. Remove the gel from the patient's skin with a tissue. 7. Perform the ABI procedure in a U configuration, moving from right arm to right ankle to left arm. 8. To measure the ankle pressure, palpate the area around the medial malleolus to find the posterior tibial (PT) arterial pulse on the inside of the ankle. 9. If this pulse is palpable, apply an approximate 1 inch of ribbon of Doppler gel to the area. If there is no palpable pulse, apply Doppler gel to the general area. Turn on the Doppler probe and move the probe around until the clearest arterial sound is heard. Keep the probe in the position where the clearest arterial sound is heard. Inflate the cuff as before, followed by deflation and recording as you did for the brachial artery. 10. Perform the same procedure on the dorsalis pedis artery. Palpate the dorsal arch of the same foot for the dorsalis pedis (DP) arterial pulse. 11. On the opposite ankle, obtain the PT and DP pressures as before in steps 8, 9, and 10. 12. Repeat steps 2 through 6 on the remaining arm. 13. To obtain the index, divide each DP and PT pressure by the highest brachial pressure. Record the number as a decimal. Both the DP and PT arterial pressures are measured to provide a complete assessment of the extent of PAD in each limb. Additionally, some patients may have a congenitally absent dorsalis pedis pulse. Other patients, particularly some elderly and diabetic individuals, have calcification in their arteries that prevents occlusion of flow by the blood pressure cuff. This will cause an abnormally high reading. Typically, any reading greater than 1.4 is considered abnormal. Such patients should have additional testing in the vascular laboratory. ABI interpretation and next steps. When an ABI is checked, there's already some degree of clinical concern or suspicion for peripheral artery disease based on an individual's risk factors, symptoms, and exam findings. One key to keep in mind, at any stage in the PAD or atherosclerosis disease continuum, and even in the absence of atherosclerotic disease, prevention is key. In the case of a normal ABI, primary prevention measures will reduce the risk of developing clinical disease. In the case of an abnormal ABI, secondary prevention limits the progression of PAD and reduces the risk of subsequent limb events such as chronic limb-threatening ischemia. There are recommendations and specialists who can assist at different stages of progression. Let's look at an ABI, keeping in mind that this is just one tool available in a PAD assessment. Then we'll consider the test interpretation and next steps in prevention and treatment, starting with the calculation of the ABI. Each leg will have its own ABI. The ABI is the higher pressure of the two arteries at the ankle, dorsalis pedis or posterior tibial, divided by the higher brachial, upper arm, systolic pressure. This ratio is the ABI or Ankle-Brachial Index. If this ratio of the ankle pressure to the upper arm pressure is a little over 1, this means the pressures in the leg and arm are similar, where the pressure in the leg is a little higher. This would be the normal and expected finding in leg arteries without narrowing or disease. An ABI much below 1 would indicate that the pressure is lower in the leg than in the arm. This would be abnormal and indicate likely narrowing of an artery or arteries in the affected leg. Another situation to be aware of. An ABI can be misleadingly elevated much higher, above 1.4, if the leg arteries are calcified or hardened. This is common in patients with diabetes or chronic kidney disease, where the stiff arteries cannot be compressed by the blood pressure cuffs. The ABI is not as reliable in this situation. Let's review some ABI values, their interpretation, and some next steps to consider given that test outcome. In all cases, it is recommended to address key lifestyle measures such as nutrition, exercise, and tobacco avoidance to identify and treat modifiable risk factors. An exercise ABI can be a helpful next step for patients with a normal or borderline resting ABI, but who describe claudication symptoms or for whom there remains high clinical suspicion of PAD. The exercise ABI is a non-invasive test that entails checking the ABI at rest. and then again after a specified walking protocol to get a sense of how the ABI changes with exertion. If the ABI result is unclear or if further diagnostic testing is being considered, vascular care specialists can be helpful consultants in the care and treatment of these patients. When it comes to subspecialty consultations, the clinical expertise and workflow are specific to each institution. For some institutions, vascular surgeons lead invasive angiography and endovascular care. For others, such interventions may be managed by interventional cardiologists specializing in peripheral artery disease. Interventional radiologists also perform peripheral artery imaging in some health systems. If you care for patients with PAD, it's a great idea to get to know the team at your institution and in your region to coordinate care. For patients with any stage of PAD based on ABI, and often based on additional diagnostic testing, lifestyle and medical management are key. Following a dietary pattern promoting cardiovascular health, such as the DASH diet or dietary approach to stop hypertension, facilitating about 30 minutes per day of moderate intensity exercise, and supporting all patients to become non-smokers and non-users of tobacco are essential steps. Engage the clinical team caring for patients to optimize the treatment of underlying conditions. Medical treatment for mild, moderate, or severe PAD can be managed in coordination with a vascular medicine specialist to prevent the progression of disease and preserve limb function. Treatment for PAD is tailored to each patient and ideally includes antiplatelet therapy with aspirin or clopidogrel, lipid-lowering therapy, often with statin therapy, ezetimibe, and/or PCSK9 inhibitors to attain LDL cholesterol goals. Home blood pressure monitoring and hypertension treatment, preferably with an ACE inhibitor or ARB medication. Tobacco cessation treatment as needed and treatment of diabetes. Low-dose anticoagulant treatment with rivaroxaban is also helpful in certain cases. For patients with claudication symptoms, referral to supervised exercise therapy is recommended, and the medication cilostazol may be of help. Thank you all for your participation in this vodcast. We have covered numerous critical aspects of peripheral artery disease, and your contributions will have a significant impact on the PAD community. And in closing, I'd like to remind everyone listening to encourage your patients to play an active role in their medical care by advocating for themselves and their family members. To get additional information, please visit AHA's PAD for Professionals website for more education. Thank you.